Hi, I'm Mohammed Jahanzeb. I'm a medical oncologist in Boca Raton, Florida. I focus on lung cancer and breast cancer, and I work with Florida Precision Oncology, a division of 21st Century Oncology.
Hi, I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Kidney Chemo Cancer Center at Sibley Memorial Hospital in Washington, D.C.
I'm Michael Lanuti. I'm a thoracic surgeon at Mass General Hospital. I'm the director of thoracic oncology in our division of thoracic surgery, and I'm an associate professor at Harvard Medical School.
Hi, I'm Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I am chief of thoracic radiation oncology and stereotactic body radiotherapy and director of clinical trials.
Hi, I'm Michelle Ginsberg. I'm a radiologist and I'm director of cardiothoracic imaging and vice chair for education at Memorial Sloan Kettering Cancer Center in New York City.
So let's turn it over to Dr. Lanuti.
So this is a robust young Italian male born in Italy, came to the U.S., worked as in construction, and then opened up his own automobile shop for the past 20 years. Smoked cigars only after smoking about one pack per day for 15 years of tobacco for cigarettes. He had no known asbestos exposure. Yes, he worked on brakes in the automobile industry, but that's the history that's pertinent. As mentioned, he had a cough. That's what prompted the imaging. The effusion was tapped. It was cytology negative. This we'll see some imaging in a second, but this lesion or the solid part of his lesion was kind of mediastinal next to the esophagus, which prompted the endoscopic esophageal ultrasound, EUS, with a fine needle aspiration, which revealed atypical cells. He had another thoracentesis in the workup, which started to potentially show some neoplastic cells with the immunohistochemistry that's listed, albeit remember that diagnosing mesothelioma from pleural cytology is often difficult. So perhaps Dr. Ginsberg can comment here.
So on these images, we see the 3 by 2.8 centimeter mediastinal mass, which may be within the mediastinum or alternatively probably in the mediastinal pleura. The effusion adjacent to it is moderate size, and the mediastinal pleural base mass was FDG avid with an SUV of 17.4, as seen on the corresponding PET CT.
So he needed a diagnosis. It was clear we had maybe a suspicion of a mesothelial neoplasm based on pleural fluid, but we often discount that. So he ended up going for direct inspection of his disease with right thoracoscopy and pleural biopsy. And to control the pleural effusion, we have options of drainage with a chemical pleurodesis versus putting in a pleurexed catheter. Many surgeons would do one or the other. I think the movement is more towards pleurexed catheter because it leaves many options open. The biopsies, the histology were an epithelioid mesothelioma, WT1 positive, calretinin positive. Of note, the right VATS showed multifocal disease, not only that primary lesion near the esophagus, but there was scattered disease throughout the pleura and on the diaphragm. Also of note, BAP1 expression was intact. The PDL1 status was less than 5%. And tumor infiltrating lymphocytes also, part of that is less than 5%.
Great. So let me go to Dr. Levy. If you were sitting around the tumor board table, what would be your advice at this point?
This is where you really have to partner with your surgeons to see, even with the pleural biopsy, would there be a role for surgery for a young, fit guy who's motivated? Outside of surgical options, the general systemic approach for an epithelioid malignant pleural mesothelioma is cisplatin or carboplatin with pemetrexed. We've had data, some mixed data, but we do have a phase 3 trial that adding bevacizumab to platinum pemetrexed compared to platinum pemetrexed alone provides a survival advantage. So outside of surgical options, if surgery is not on the table, and I would take my cues from the thoracic surgeons and how they could approach this, I would offer this patient systemic therapy. But this is a call for clinical trials and a call for science because we need to do better in this disease. It's rare, it's unforgiving, it's a challenging diagnosis, it's a challenging treatment. But bottom line is I'd offer platinum, pemetrexed, bevacizumab, and then you can talk about the controversies of which maintenance you should continue. But I usually continue both the maintenance pemetrexed and the bevacizumab after 4 cycles in the absence of any really good data.
So what I hear you saying is that if patient was going for surgery and you were to give systemic therapy before, then you would choose the non-bevacizumab option.
Yeah, I think that's important. If the surgeon thought, look, we're gonna the high volume, high experienced surgeon like Dr. Lanuti saying, look, I can do this. I'd like to start with some induction. I wouldn't give bevacizumab. The bevacizumab is probably contraindicated in somebody who's going to go off into surgery. Although you could make the argument that it may improve the response rates, and there is data in lung cancer for neoadjuvant cis-pem-bev. But outside of the clinical trial, I would probably offer 4 cycles of cisplatin pemetrexed and then turn them back over to the thoracic surgeon.
But if you did give bevacizumab, tempted by increasing the response rate or likelihood of response, then you would build a longer interval between the last dose of bevacizumab and surgery?
Yes, that I probably wouldn't give it on the last dose. If
Okay.
we're going to do 4 cycles, I would just admit it on the last dose. Or you could space out, make sure you at least have, I think, 28 days in between the initiation of bevacizumab and the invasive procedure or surgery.
You mean delivery of bevacizumab or the end of that cycle of bevacizumab
Right.
in 28 days?
Right. Yeah.
Yeah.
So I felt he was a surgical candidate. You know, in the surgery realm, we debate what is our best strategy. Do we remove all disease? Do we do pleurectomy, decortication, radical pleurectomy, or do we take out the entire lung, extrapleural pneumonectomy, and all the pleura? That debate, and that has been moving across the field in the past few decades, where there is a general movement towards less extrapleural pneumonectomies given the morbidity. There are some retrospective series that suggest that the pleurectomies do just as well as the extrapleural pneumonectomies. There's a Mars trial, which wasn't ideal, but ended early, that looked at this and suggested that there was no big benefit from an extrapleural. Nonetheless, we tailored to the patient, and he was felt to be someone that I would take for probably a pleurectomy, and I opted for induction therapy. He got 4 cycles of cis-alimta, and then we restaged him on this imaging. Dr. Ginsberg, maybe you can just, and he also got an esophagoscopy based on the where the tumor was.
So on the left-hand side, we see a chest X-ray, which demonstrates blunting of the right costophrenic angle. So probably a small residual pleural effusion or pleural thickening. As far as the mediastinal pleural-based lesion, it wouldn't probably be seen on this image. And we see the CT, which doesn't really, it demonstrates a little bit of soft tissue, but really not that much, right behind the trachea and next to the esophagus. And the esophagram, it's only a static image. Generally, we look at like a video of it and numerous images, but looking at it, it looks like there's some mass effect on the esophagus, which is probably from this residual soft tissue density, which is compressing the esophagus.
So he was taken to resection with a thoracotomy, pleurectomy. If there's a lot of disease in the diaphragm or the pericardium, I will remove it and replace it with a prosthetic replacement, most likely some kind of plastic or PTFE we call. It's a something that we often use for reconstruction of the diaphragm. He did end up having an esophagoscopy when we started, and there's a picture of it there, which we did not biopsy until many weeks later. That ended up being, in retrospect, positive for mesothelioma. So that is that the posterior mediastinal tumor was pushing in that area against the esophagus. and it was actually ends up being in the wall of the esophagus, which in retrospect, if I knew that, I would not have offered him this operation. So I can pause there and then we can take comments. This patient did not do very well. His disease came back very quickly, and he was offered adjuvant immunotherapy and succumbed to the disease very quickly.
So let me ask Dr. Levy again. Tell us about immunotherapy in mesothelioma.
Yeah, we've got some recent data as of April 2020. A pivotal phase 3 study, Checkmate 743, evaluating nivolumab plus ipilimumab, nivolumab being a PD-1 drug, ipilimumab being a CTLA-4 drug in combination. This is a combination used in non-small cell lung cancer too that also has an approval. And it was compared directly to chemotherapy, platinum pemetrexed, and untreated malignant pleural mesothelioma. And we saw a survival advantage in this trial, a meaningful improvement in overall survival. At least we've seen early results of a survival advantage. And so I think this is beginning to change the way that we think about the role of dual checkpoint blockade. That's a fancy way of just saying adding a PD-1 drug with a CTLA-4 drug. Prior to Checkmate 743, we did have data in patients who had disease progression on platinum pemetrexed. So there was single agent activity with nivolumab, and then also activity with nivolumab plus ipilimumab. But this Checkmate 743 will, I think, change the calculus for some fit patients who have untreated malignant pleural mesothelioma, and it may be offered in lieu of chemotherapy. So we'll have to see how this all pans out in clinical practice.
Yeah, always good for patients to have additional options. So let me ask you, Dr. Lanuti, and maybe Dr. Levy can chime in. Any experience with or any opinion about intrapleural cisplatin therapy?
Yeah, that's a tool that's been pioneered by our companion institution in Boston, Brigham and Women's Hospital. I think that they've never really published prospectively on that approach. I think that we understand that they've had some successes, but a lot of toxicity. They've had actually a lot of deaths early on. And so it is something that I believe that they're doing less of, but it's still being offered. And it's much, much more refined now than it was. So it is not something that we do at our institution at Mass General, but it is out there and promulgated mostly by one institution in the country.
So you're clearly saying don't try this at home.
I think that's fair.
Okay. Dr. Levy, any experience at Hopkins?
Yeah, I don't have anything meaningful to add here. We don't do that. I think this has been driven by a few folks with lots of experience, but something that I'm not too familiar with or our institution is.
Can I interject? Because we have another modality here.
Sure.
So I would just say that, like, historically, when it was much more common to provide extrapleural pneumonectomy, we would often integrate postoperative radiation in that. That was always done with extreme caution, because when you're left with a single lung, there's risk of fatal pneumonitis. In the new era where we're switching towards many more patients getting pleurectomy and decortication instead, there's now a significant resurgence in interest with modern radiation techniques, published in Italy and actually at Memorial Sloan Kettering, with the notion of using kind of comprehensive intensity modulated radiation to treat the rind of lung in an intact lung. Again, not to be tried at home, as you say, but certainly of interest, because particularly epithelioid mesothelioma can be quite sensitive to radiation. The problem is its pattern of failure is such that it can escape anywhere. But the morbidity of local progression in these patients is not to be diminished. The considerable effort that we put into trying to deal with their pulmonary reserve and breathing and pain is something that sometimes I think more aggressive upfront treatment can be warranted.
Thank you. No, I should have asked you. I apologize. But this actually gives us a 360 view from a radiation surgery and medical oncology standpoint. This has been a truly enlightening discussion. I thank all of you These were phenomenal cases, all requiring multidisciplinary input, and it's such a treat to have world-renowned experts discussing them and coming to a consensus. Thank you all.